So aromatase deficiency. Some females may be deficient in their aromatase enzyme. This means that the newborn with a 46XX karyotype would not be making any estrogens. In terms of feedback, this means that the pituitary will keep sending signals to make estrogen. What is the precursor of estrogens again? Androgens. Therefore, these infants would have increased androgens, meaning they will have masculine features. Remember that these hormones are steroids, so they can cross the placenta. Therefore, all that testosterone in the mother could cause her to have virilization symptoms, such as deepening of the voice. Watch out for this on your step. Androgen insensitivity syndrome. Let's talk about it more in detail. So AIS is where you have a genotypic XY male with a defect in the androgen receptor. So you end up phenotypically looking like a woman. As we know, chromosomes determine primary sexual characteristics and hormones determine secondary sexual characteristics. As XY males, AIS patients have testes that secrete testosterone, but a body that cannot respond to the testosterone. As we said, this leads to increased LH and increased T because of the lack of negative feedback. The testes also secrete some estrogen, which is unopposed in the absence of testosterone's effect. So as a result, these patients develop normal breasts, a normal lower vagina, and normal clitoris. However, they don't end up developing uterus, cervix, upper vagina, or fallopian tube. So why is that? That's because the testes are still making anti-Mullerian hormone. But the one thing that really differentiates this condition from others is that there's no pubic or axillary hair. Pubic/axillary hair is androgen dependent. This will be the giveaway between AIS for a 46XY patient and Mullerian agenesis for a 46XX patient, where the patient looks the same, but as you can see on this table, there would be some differences. The testosterone levels in androgen insensitivity syndrome are at male levels, whereas Mullerian agenesis will have normal female levels. Of note, Mullerian agenesis is essentially a female with no internal sexual organs because her paramesonephric ducts just never developed. Another important point is that patients with AIS need gonadectomy due to the risk of malignancy, whereas patients with Mullerian agenesis need renal and skeletal evaluation with ultrasound or MRI due to the risk of abnormalities. Do you know what kidney abnormality is often associated with Mullerian agenesis? Horseshoe kidney it is. Back to AIS. All this is going to result in a normal appearing female with female external genitalia, but with a blind-ended vagina and no uterus. Internally, they actually have testes, which are found in the labia majora or in the inguinal canal. Here's a picture of women with AIS. Again, they are male by genotype, but externally you cannot tell them apart from other women who are XX. Here's another good disease to know. So here's testosterone. What is the function of 5-alpha reductase again? It's the enzyme that converts testosterone to the much more potent dihydrotestosterone. So with this disease, these XY males lack the potency of DHT, and so they will have ambiguous genitalia until puberty, at which point you get a significant increase in testosterone levels. In some cultures, in which this condition is relatively common, patients are raised as girls until puberty when they unexpectedly develop male secondary sex characteristics, like the descent of testes, deepening of the voice, hair growth, etc. At that point, they may transition into a more male role in society. In terms of the biochemistry, the levels of testosterone in these patients tends to be normal, so you have normal T, but the LH level may be increased. The only other thing to keep in mind is that, as you will recall from the genetics unit in biochemistry, this conforms to the pattern that most enzyme deficiencies are autosomal recessive in inheritance. Alright, here's a flash quiz. Patients with androgen insensitivity syndrome lack a uterus, the upper third of the vagina, a cervix, and fallopian tubes. The presence of what hormone is responsible for this? That's right, it would be anti-Mullerian hormone. As I mentioned earlier, Kalman syndrome is an example of hypogonadotrophic hypogonadism. This is Board's testable because it demonstrates what happens when the hypothalamus fails in sex hormone regulation. Kalman syndrome is a defect in the brain caused by the improper migration of the GnRH secreting neuron during development. So here's GnRH over here. Low GnRH causes decreased synthesis of gonadotropins, leading to low FSH and low LH. The result is delayed or no puberty and a lack of secondary sexual characteristics. Females won't menstruate and won't have normal breast development. Males might end up with a micropenis. The defect in the brain is also located at an olfactory center, so these patients also have anosmia. On the boards, if you get a question about a patient who can't smell and has a lack of secondary sexual characteristics or amenorrhea, think Kalman syndrome. The anosmia is a good way to keep it straight when you have to decide between this disease and several of the other disorders of sexual development. The bottom line is that Kalman syndrome presents with 1. Anosmia, 2. Secondary hypogonadism, and 3. Renal abnormalities in about half of the patients. So, let's talk now about a disease that causes an increase in HCG production, the hydatidiform mole. The hydatidiform mole is also known as gestational trophoblastic disease. You can think of it as a fertilized egg that wasn't able to form a normal zygote and began to develop. Instead, you get a cystic swelling of the chorionic villi and a proliferation of the chorionic epithelium. As this is a disease that happens inside the placenta, there will be trophoblastic tissue and chorionic villi present. In terms of question stems, you should suspect a hydatidiform mole when a pregnant woman presents with vaginal bleeding with or without anemia, morning sickness that extends beyond the first trimester due to persistently elevated HCG, or hypertension before 20 weeks of gestation. Just for reference, what anatomical landmarks should the uterus be at 12 weeks and at 20 weeks? Respectively, it should reach the pubic symphysis at 12 weeks and the umbilicus at 20 weeks. So, the classic way to diagnose a hydatidiform mole is by ultrasound, where you have a characteristic snowstorm appearance. You would also think of a hydatidiform mole if the patient has a uterus bigger than would be expected given the gestational age, as seen as in this ultrasound. You can see how huge it is. The snowstorm appearance on the ultrasound is another one of these medical buzzwords that's worth knowing because it's always used in this context. Cluster of grapes is another buzzword that's often used. Moving a little further, the next thing to think about when getting a question on moles is whether the mole is complete or partial. So what does that mean? So a complete mole occurs when a 23 chromosome sperm joins an empty egg. As the egg has no chromosomes, the 23 chromosomes in the sperm duplicate, so the resulting zygote is 2 times 23, 46 chromosomes. Much less frequently, 2 sperm can fertilize an empty egg at the same time, so you get a diploid zygote that has chromosomes from 2 different sperm. On the other hand, a partial mole occurs when 2 sperm join one egg that still has its chromosomes, so you get 69 chromosome zygote. Both complete and partial mole will have increased HCG, more so for the complete mole. They are both treated the same, with dilation and curettage, and sometimes methotrexate. After treatment, further monitoring is done by checking the beta HCG levels, which should drop back down to normal by 3 months. So what would you be worried about if the beta HCG level does not go back to normal? Well, again, you have to worry about malignant trophoblastic disease. This can occur anytime there is pregnancy, including ectopics, miscarriages, but most commonly with moles. Your index of suspicion is determined by which type of mole you had in the first place. A complete mole has a 15 to 20% chance of converting to malignancy. On the other hand, partial mole has a low risk of malignancy, less than 5% of developing. If it were to develop into malignancy, choriocarcinoma is a very aggressive type that either a complete or partial mole could give rise to. So, here's a pretty high yield segment for you for both the boards and your eventual OBGYN rotation. Let me preface this by saying you are more at risk of developing gestational hypertension, also called pregnancy-induced hypertension. Sometimes we call it PIH. If you have pre-existing conditions like hypertension, diabetes, chronic kidney disease, or other immune disorders. So the causes of PIH are not really clear, so not really board testable, but the mechanism is generally accepted to be placental ischemia in the setting of uterine spiral arteries that aren't able to vasodilate. This may occur if the placenta is shallowly implanted. So at PIH, you would have a BP over 140/90 after 20 weeks. So hypertension after the 20th week of pregnancy. Preeclampsia is relatively common, occurring in about 7% of pregnant patients. In these patients, can you remember the classic triad? You get hypertension, proteinuria, and edema, or swelling. An even worse version of preeclampsia is eclampsia, where you get preeclampsia plus seizures. In terms of presentation, you may see preeclampsia or eclampsia with the HELP syndrome. HELP is an acronym for hemolysis, elevated liver function test, or LFTs, and low platelets. The main causes of death in this situation are cerebral bleeds and an acute respiratory distress syndrome. What would a peripheral blood smear show in HELP syndrome? You would see schistocytes. So you can see them over here, some over here, some over here. All right? So the definitive treatment for preeclampsia is to deliver the fetus as soon as possible. It's extremely important that you know that answer for your boards. However, if that would be dangerous to the fetus or the mother does not want to deliver early, the best course of management is to keep the blood pressure down with bed rest, salt restriction, and special antihypertensive. You may remember from cardio that these would include alpha-methyl-dopa and hydralazine. Okay. For eclampsia, the seizures can be treated with IV magnesium, MgSO4, and diazepam. But definitive treatment is delivery of the infant. So here's a flash quiz. A patient presents with vaginal bleeding and a sudden blood pressure of 150/95 at 8 weeks of gestation. What is the likely diagnosis? That's a hydatidiform mole. Of note, had I said proteinuria and elevated BP at 25 weeks of gestation, then the likely diagnosis would be preeclampsia.